comes from symptomatic patients. And the first thing we have to fix is the answering the question, does the risk of stroke change if patients are less symptomatic? Now, the recent development of technology has enabled a number of tools to be developed that allow us to pick up rhythm irregularities. And some of them are summarized in this figure that was proposed by Indrix and co-workers in the last ESC guidelines on atrial fibrillation. When compared to EKG, the reliability of available technologies in different methodological settings has proven to be very high, in the range between 85 and 99% for both sensitivity and specificity, when considering pulse taking, automated blood pressure monitors, single lead EKGs, smartphone apps, and watches. The medical community was very excited about the possibility to access to this unprecedented information regarding the possible presence of heart rhythm irregularity. And I was a little bit surprised about this enthusiasm, because it was clear to me that the amount of information that was about to come to us would be overwhelmingly high, something that we would not be able to handle. But again, sensitivity and specificity being so high were prerequisites for people to excite about this. What is the clinical context of subclinical atrial fibrillation? There are essentially, well, the definition is a little bit elusive, and for the purpose of this presentation, we will consider subclinical atrial fibrillation as atrial fibrillation occurring in patients who are asymptomatic or whose symptoms deviate us from considering the possible role of atrial fibrillation as a causative factor. There are essentially three conditions that may be recognized under the umbrella of subclinical atrial fibrillation. They include cryptogenetic stroke, device-detected atrial fibrillation, and screen atrial fibrillation. Screening atrial fibrillation is a population-based effort, and costs and benefit of this effort need to be carefully taken into account. Now, on a population-based model, screening atrial fibrillation is proven to lead to atrial fibrillation detection in a proportion ranging between 0.8 and 1.4%. And because the stroke risk of this population is still unclear, but certainly much lower than the stroke risk observed in symptomatic patients with atrial fibrillation, the dedication of any program in this direction with the mission of providing a target for anticoagulation therapy is still open. The second topic is cryptogenetic stroke. In this population, atrial fibrillation can be detected in a much higher proportion of cases. You see 23%. And the ability to accurately detect atrial fibrillation in this population has raised a lot of enthusiasm about the possibility to treat this patient with anticoagulation therapy in order to prevent stroke risk in the future. There were two trials that were designed and conducted with the purpose to randomly assign a novel oral anticoagulants, rivaroxaban, versus standard of care aspirin, having as a primary efficacy endpoint the proportion of patients with stroke or peripheral embolism, and as primary safety endpoint the proportion of patients with major bleeding events. Now, Navigate ASUS here showed no benefit in terms of stroke prevention, and a significantly increased risk of major bleeding, 270% higher. In respect ASUS, a similar model was tested, and in this case, the bigatron was compared with aspirin. There was not a significant increase of a bleeding risk in this group, but however, there was no significant benefit in terms of stroke risk prevention, and therefore oral anticoagulants are not indicated in this population at present time. In device-detected atrial fibrillation, there was a much higher power on our side to calculate the AF burden and to fix in this parameter a potential predictor to more accurately discriminate between patients at risk of stroke versus those at lower risk. 2 studies have been conducted to investigate the role that random assignment to a novel oral anticoagulants versus standard of therapy would increase our ability to protect these patients from stroke risk. One study was NOAA-AFNET and the second study was Artesia. The pooled estimate of all-cause mortality and major bleeding events observed in these 2 studies led to the observation that assignment to a novel oral anticoagulants for protective purposes would expose the overall population to a higher risk of all-cause mortality or major bleeding, which reached statistical significance when major bleeding only was considered, whereas no benefit was proven in one of the study and a trend towards some benefit was proven with regard to the others. And this leads us to consider that there is at present on solid methodological basis no conclusive evidence about the potential benefit from novel oral anticoagulants versus aspirin. So the summary is that early detection of AF is now feasible by means of a number of tools and methodologies provided by high diagnostic sensitivity and specificity, and use of artificial intelligence to enlarge our discrimination power and our efficiency when using the enormous amount of information that we may be collecting from these technologies is reasonable. However, the effort required to generate this information is high, as it is when it is performed in a population-wide community. The amount of data generated is larger, usually beyond the capability of human mind to cope with it for usable clinical purposes. And finally, I like to go back to a very old image of the finger pointing to the moon. And if artificial intelligence is looked as an early detection means to identify atrial fibrillation in patients or individuals who are not aware of it, we should not forget that our real target is how do we translate this information into a clinically meaningful strategy. And to this aim, all information we have at present shows that use of anticoagulation therapy in this population is not leading to a reduced risk of stroke, and therefore early detection of atrial fibrillation does not translate into a benefit on this specific aspect. What are the other potential benefit that we may gain from this enormous effort? Electrical mechanical atrial remodeling could be prevented. AF-related hemodynamic derangements, atrial and ventricular tachycardia induced cardiomyopathy. I think we all agree that the evidence to prove that this kind of benefit is determined is not present at present. Prevention and reduction of AF related morbidity, hospitalization, and mortality. This needs to be tested in the next future, and reduction of the outcomes associated with conditions and diseases associated with AF that are discovered and treated as a consequence of the examination prompted by AF detection. This can be useful on a daily basis, but certainly there is no conclusive evidence that is going to change our patients' risk. And on the other side, we have to take into account the risk of abnormal results that may cause anxiety, EKG misinterpretation leading to overdiagnosis and overtreatment, and detection of other abnormalities that may lead to invasive tests and treatments that have the potential of serious harms. Thank you very much for your attention.
Thank you, Professor Capetto. I have a small question. When there is no risk factor by CHAD, but the patient has prolonged attacks of atrial fibrillation, do you give him anticoagulant?
Now, if we go back to the pre-CHADS-VASc era, you may recall that CHADS had a lot of disadvantages, but had one major advantage, which was if CHADS was 0, no treatment. If CHADS was 2, treatment. If CHADS was 1, you were left to whatever decision you took based on an individual basis. So it led physicians with a high flexibility of clinical judgment in the individual case. And I would respond to your question by bringing us back to the CHADS 1 classification category. In CHADS 0 or CHADS-VASc 0, I would hesitate to use anticoagulation therapy. And I think we have now even more evidence in categories with atrial fibrillation and maybe CHADS 1 or CHADS-VASc 1 or 2. There may be very selected cases. Now, there are patients with thromboembolic events, peripheral, with severe atherosclerotic disease, which does not account for CHADS-VASc, with kidney dysfunction, in which you may consider anticoagulation. But certainly this would be the exception rather than the rule.
Yes, I'm speaking about certain patient who was young, with prolonged attack, CHAD 0, has no other comorbidity, has severe headache. I said, no, it's maybe your sinusitis. It happened to be occipital, embolic occipital infarction. So I learned since that time, if a patient has prolonged attack, many hours, frequently, although he has CHAD 0, I can start anticoagulation.
But could you establish the cause for that?
He has no other cause except this prolonged attack of atrial fibrillation, frequent prolonged attack.
I would certainly consider this.
I actually said that in another meeting, and one of the American experts said, I agree, I have similar experience. We can have exception, as you said, selected patient like this example. Hours and frequent. But of course, as Professor Capetto, these people who detected minutes does not have to give anticoagulants.
Was this patient proposed for catheter ablation of AF?
Actually, this time, 20 years ago, it wasn't, ablation was not.
If this happened nowadays, certainly this would be a case that can be proposed for catheter ablation. Okay. And in that case, I would be very aggressive. I'm not usually aggressive, but I think aggressiveness to obtain or to aim for a curative treatment, even after multiple procedure, in this case, has an extra payback value.
I see. Agree.
Score one in ChatVask, I give it anticoagulants because once I saw a patient with atrial fibrillation, score one only, did not give anticoagulants, and weeks he came with ischemic lesion. So I will never, any patient with atrial fibrillation, I give anticoagulants.
You see, classification in the intermediate risk score is difficult to judge. And I think everybody would be influenced by his, her personal experience. But I would kindly discourage you from using a previous example as a platform to guide you in every subsequent future experience, because as we mentioned before, we have the privilege of clinical judgment, and I know your huge clinical experience, so I would strongly encourage you to use it in the individual case, presenting to you regardless of the CHARTS-VASC classification. Remember, these are useful tools, but should not be used as laws. And I understand that this is difficult during a time when the ESC is trying to push, to promote laws from their guideline documents.
Professor Capato, thank you for the elegant presentation. We have this patient, real life. He is young, 40 years old, came to us with asymptomatic atrial fibrillation for 10 years. He was diagnosed once and then discharged home, and he never felt any problem, and then discovered by ECG and referred to us after 10 years. We tried anticoagulated him, we tried DC shock. After TE, nothing. DC shock failed to convert him to sinus rhythm 3 times, so we postponed this trial. But the question was there. He is in long-standing persistent AFib. We don't want it to be permanent, but what if this patient at any time converted to sinus rhythm? If we do the conversion, we give anticoagulation for 4 weeks if it is longer than 48 hours, even in CHAD-0. If we think it like this, in the same way, what if this patient, for any incidence, he converted to sinus rhythm?
When considering the risk within each CHATS or CHATS-VASC category, we are pulling patients with different characteristics. And the 2 examples that you have, actually the 3 examples that you have brought here, represents very different situations within one single CHATS or CHATS-VASC category. And this is why I think risk scores as well as guidelines should be considered as references to us, but we should always take the privilege of our clinical experience to renovate our judgment in the individual case. And nobody is perfect. We have to live on a daily basis with the assumption that patients might pay the price of the decision we are going to take now. But if the decision is taken on a clinically sound judgment, I think this is the best that we can do. And therefore, I wouldn't be influenced for the rest of my life if a patient's developed some inconvenience based on a clinically meaningful decision I took. There is the law of fate beyond everything we do that applies to everybody's life, and we should be able to live, I would say, with lightness with it, with responsibility, with responsible lightness, so to say.
Thank you. For the time being, we go to next speaker, Professor Tretto, who will speak about drug for prevention of atrial fibrillation. Think outside the box. Professor Tretto.
Thank you very much again, dear chairperson, dear friends. let me thank again the organizing committee for this kind invitation. I'm very glad and proud to be here with you today. I've nothing to disclose from the commercial standpoint, but actually I'm an interventional electrophysiologist actively performing atrial fibrillation, catheter ablation procedure, and thus a certain conflict of interest with the topic of my presentation, that is primary prevention of atrial fibrillation, could exist. Of course, I'm joking. As you know, atrial fibrillation is the commonest sustained tachyarrhythmias. The worldwide prevalence is estimated roughly 50 million individuals currently. And this huge figure is expected to dramatically increase in the next years due to the aging of the population, the improvements in acute disease treatment. In other words, these people survive more, live longer, and they have to face with the complication of the acute diseases. With the growing spread of unsafe lifestyles, and last but not least, due to the greater focus and awareness that is presently addressed to this condition. Awareness that is fully supported by the important, relevant clinical consequences of atrial fibrillation, not only death, stroke, or heart failure, which in turn translate into higher healthcare utilizations and costs. Atrial fibrillation treatment, whatever they are, anticoagulants, antiarrhythmic drugs, catheter ablation, whatever you want, although nowadays they are more effective and safe, cannot be the solution, or at least the only solution for this problem. And in fact, the only cost and risk effective strategy to reduce the global atrial fibrillation burden is to tackle all modifiable risk factors at a very early stage, that is before arrhythmia develops. And actually, the risk factor treatment do represent the foundation that support the pillars of atrial fibrillation management. These risk factors include heart failure, very low or excessive exercise, arterial hypertension, diabetes, smoking, obesity, excessive alcohol consumption, and breath disorders during sleep. And all these risk factors should be timely, properly treated in order to prevent atrial fibrillation occurrence, as strongly recommended by the current guidelines. Why these factors are important? They, in different way, they can activate multiple mechanisms and paths, either cell or tissue level, resulting in electrical, autonomic, metabolic, and structural arterial remodeling that in turns translate into a greater propensity in atrial fibrillation initiation and maintenance. Non-antiarrhythmic drugs with direct or ancillary properties able to control or modify this condition, in particular arterial hypertension, diabetes, heart failure, and to interfere with several arrhythmogenic mechanisms, for instance, renin, angiotensin, aldosterone activation, systemic inflammation, oxidative stress, fibrosis, may prevent the occurrence, this primary prevention, or abolish or reduce secondary prevention AFib episodes. So moving to the individual risk factors, atrial fibrillation is very frequent in patients with elevated blood pressure. 70% in the epidemiological studies, from 50 to roughly 90% in randomized clinical trial, and thus arterial hypertension is the commonest, probably one of the most powerful risk factors for atrial fibrillation occurrence, since it causes hemodynamic alteration, arterial stretch, arterial dilatation. It activates the renin-angiotensin-aldosterone systems, leading to secondary mechanisms. And also it provides an autonomic nervous system dysregulation, all of them leading in atrial inflammation and fibrosis. And based on this consideration, now the question is whether an aggressive blood pressure control, that means a systolic blood pressure below 120 millimeter of mercury, is better than a standard control that is less than 100 millimeter of mercury in terms in preventing atrial fibrillation. And this hypothesis was tested by a recent post-hoc analysis of the SPRINT trial that have enrolled more than 8,000 patients with arterial hypertension. And actually the results of this study demonstrate that a more aggressive treatment is associated with a significant reduction of the risk of atrial fibrillation, and the estimated difference is minus 26% at a follow-up of 5.2 years. However, if you have a closer look at the raw data, you can see that the true difference in terms of cases is rather small, at least clinically rather small, only 2 cases every 1,000 people per year. And more, in addition, these figures are also very likely underestimated due to the really weak atrial fibrillation screening performed during this study. This patient underwent only one standard ECG every 2 years. So moving to the different classes of blood pressure lowering agents, to the effect of different classes, this data come from study published. We have data regarding ACE inhibitors, ARB, and mineralocorticoid and receptor antagonists, because these are the only agents that may prevent or revert electrical and structural remodeling due to their ancillary properties. They have to recall that this data comes from retrospective post-hoc analysis of large randomized clinical trial that have enrolled in the last year, mostly patients with heart failure. And the results are summarized in this not really recent meta-analysis, again showing that ACE inhibitors and ARBs are associated with a statistically reduced, but again, rather clinically modest effect, reduction of risk of incident atrial fibrillation, minus 21%, minus 22%. All the anti-aldosterone agents, spironolactone or eplerenone, also are associated with a significant reduction of incident atrial fibrillation in these other meta-analysis, minus 48%, as well as the newer agents, non-steroid agents, finerenone, in patients with chronic kidney disease and type 2 diabetes. But again, please note that the difference, although statistically significant, is really modest in terms of clinical standpoint. Diabetes is another condition promoting atrial fibrillation occurrence through glycemic fluctuation. oxidative stress, inflammation, leading to structural, electrical, and autonomic remodeling. The glucose lowering therapies show to among glucose lowering therapies metformin and pioglitazone, but not rosiglitazone, demonstrated to reduce the risk of incident atrial fibrillation. Insulin increases this risk probably because of the hypoglycemic phases leading to sympathetic boost. The newer agents provided mixed or conflicting results. And among these, the SGLT2 inhibitors seems to work a little bit better than DPP inhibitor or GLP-1 action drugs. And finally, also PUFA, so omega-3 fatty acid, and vitamin D, despite their anti-inflammatory and antioxidant properties, fail to show any benefit in preventing atrial fibrillation occurrence in this large randomized clinical study recently published. So in conclusion, primary prevention is the cornerstone of atrial fibrillation management, and it should be strongly pursued. In face of valid pathophysiological assumption, unfortunately, the results achieved with drug targeting a single risk factor are usually modest, and therefore there is no recommendation for their use in the guidelines. Although most findings derived from post-hoc analysis or underpowered trials, and in this line further well-designed studies are required, these results are not fully surprising, since atrial fibrillation is a complex and multifactorial arrhythmia, and its pathophysiology is not fully understood, so it's not surprising that targeting a single risk factor we have no results. And thus, programs aimed to achieve a comprehensive treatment of atrial fibrillation risk factors, also including the control of physical activity, a balanced diet, weight loss, treatment of breathing disorders during sleep, may be more effective in reducing the global AFib burden. And we have promising data from studies like Legacy 1. Thank you for your attention.
Thank you, Professor Fritto. Any question from the attendee? If no question, we'll go to the next speaker, Professor Salahata, Professor of Cardiology, associate one of the chairman of this Congress. We'll speak about, is atrial fibrillation the fifth pillar for heart failure management? I think no.
Bismillah ar-Rahman ar-Rahim. My talk today should answer this question. Is AF ablation the fifth pillar of heart failure management? This is the agenda of my talk, and we'll go immediately through it. Atrial fibrillation and heart failure are two bad, intimately related friends. The presence of one invites the presence of the other one. They both have the same risk factors predisposing to both. And patients with both of them will have much worse prognosis than patients having one of them alone. Heart failure can lead to induced atrial fibrillation by atrial dilatation, fibrosis, electrical remodeling, mitral regurg, RAS activation. And atrial fibrillation also can induce heart failure, even it is under rate control, by loss of atrial contraction, by ventricular irregularity, by tachycardia, by RAS activation, adrenergic overdrive, and structural myocardial changes. the burden of atrial fibrillation, which is the percentage of time the patient in atrial fibrillation during a period of continuous monitoring. This burden of atrial fibrillation decides how bad will the patient with heart failure behave or deteriorate, and reversing this was proved to improve heart failure outcome. This very old question, does it really matter? This question maybe it doesn't matter, but for AF and heart failure, yes, it does matter. If atrial fibrillation precedes heart failure with reduced ejection fraction, this patient will have a better prognosis. Tachycardiomyopathy is greatly possible and is fully reversible by radiofrequency ablation in the absence of significant fibrosis. And this was proved by randomized controlled trials. If heart failure preceded atrial fibrillation, the prognosis is worse and multifactorial treatment is required. These are the 4 pillars of heart failure treatment. And for atrial fibrillation ablation to be or to join them as one of the pillars, it should fulfill or improve the targets of treating heart failure patients. Clinical outcomes, which is heart failure hospitalization, all-cause or cardiovascular mortality. Structural outcomes by left ventricular ejection fraction improvement, improving functional capacity, 6-minute walk test, and maximum oxygen consumption, and the quality of life improvement. We will go through the best evidence we have to see whether atrial fibrillation ablation fulfills these requirements. This is a meta-analysis of patients with heart failure with impaired systolic function. And this meta-analysis included all studies before the ESC 2020. Going into analysis of these all randomized trials, comparing atrial fibrillation with either rate control or rhythm control using medical treatment, and all receiving optimal medical treatment as well, we found that all-cause mortality was reduced, heart failure hospitalization, and was also reduced for the arm of atrial fibrillation ablation, and the side effects in patients with atrial fibrillation ablation was comparable or even somewhat less than the arm with drug therapy. A functional assessment showed that 6-minute walk distance improved also, and the same for peak oxygen consumption. A quality of life improved, and the AF recurrence also proved to be less with ablation than medical treatment. Regarding when we concentrate on the clinical or hard endpoints in patients with atrial fibrillation and heart failure, among these studies, we can find that mortality and hospitalization and stroke are improved in comparison to medical treatment, but this improvement is coming from 3 main trials: the ATTACK trial, the CASTLE-AF trial, and the Cabana heart failure trial. The CAMERA trial is a small one which showed the significant improvement in tachycardiomyopathy patients. The ATTACK trial compared patients with AF ablation versus amiodarone in patients with ejection fraction less than 40% and near functional class 2 and 3. There was improvement in the recurrence rate, and the improvement in the hospitalization and mortality was actually a secondary outcome. So the study was not powered to detect this. So it is not an accurate thing that we can rely much on. The CASTLE-AF trial compared catheter ablation versus conventional drug therapy in patients with ejection fraction 35% having an ICD, and the primary endpoint was total mortality and heart failure hospitalization, and it was followed for 37 months at least, and the outcome showed reduction of the primary endpoint for the arm of catheter ablation. However, CASL-AF had many limitations. It had too many exclusion criteria, and it could not be generalized to the general population when it was tried to be applied. Only at least 1 in 6 patients in real life will be excluded from the criteria of CASL-AF. The Cabana heart failure patients, actually, they were included according to symptoms of heart failure, not ejection fraction, and going in depth of this study, we found that it is actually a study of heart failure with preserved ejection fraction. Most of the patients are more than 50% ejection fraction. So a meta-analysis of the 4 main trials, which with ejection fraction less than 35%, had shown that all-cause mortality is not actually much affected in these mentioned trials. And the sub-analysis of CASL atrial fibrillation trial regarding the degree of left ventricular dysfunction have shown that patients below 20% ejection fraction has a much worse outcome compared to patients between 20 and 35% ejection fraction. That's why in the ASC guidelines 2020, it was recommended atrial fibrillation ablation as class 1 for patients with tachycardiomyopathy, and this was according to the camera MRI trial, and as class 2A for patients with selected patients, actually, with heart failure, according to the 3 trials which we just discussed. Soon after ESC, or even in the same time, it was this important study came out, which is a very strong evidence regarding early rhythm control and how it will improve the outcome. Here, patients with less than 1 year with atrial fibrillation were sent for ablation, patients with CHA2DS2 or more, and compared with patients referred for ablation after 1 year. And the outcome was significant. Cardiovascular death and stroke and hospitalization with heart failure or acute coronary syndrome, the composite outcome was much better in patients with early referral. Night of hospitalizations is not significantly altered. The secondary outcomes were improved. Regarding heart failure, the sub-analysis of early rhythm control therapy in patients with atrial fibrillation and heart failure have shown also improvement in the primary endpoints, and also it was concluded that early referral for rhythm control will improve the clinical benefit. However, when this was applied to general population long-term coherent study nationwide in Korea, the patients referred before 1 year had the same benefit as in the study, and with the exception of patients above 75 years old. Above 75 years old, the benefit was attenuated. In another study in Japan, published in Japan, there was assessment of predictors of improvement of left ventricular systolic function after catheter ablation of persistent AFib in patients with heart failure, and they ended with a predictor of failure if we have left ventricular end diastolic diameter more than 53 millimeter. Above 53 millimeter, you have a worse outcome than below 53 millimeter. Also, left atrium volume and recurrence was already known. Increasing left atrial volume increases the recurrence, and we usually use 60 millimeter as a diameter. The American guidelines in 2023, therefore, recommended as class 1A in appropriate patients with AF and heart failure reduced ejection fraction to refer the patients for catheter ablation. And in patients with a new diagnosis of heart failure and reduced ejection fraction, try rhythm control to check for tachycardiomyopathy and proceed for ablation. And also the guidelines gave this table to guide the physicians when to go for ablation, and when to tend to medical treatment by assessing different factors, including age, including left atrial diameter, including left ventricular function, and comorbidities. This was not the end of the debate. After, even at the same time also of the American guidelines, this brave study came out. It is the first study to test catheter ablation in patients with end-stage heart failure with atrial fibrillation. Patients, it is the Castle Heart HTX trial. Patients referred for cardiac transplantation and waiting on the list for cardiac transplantation with AF were subjected to randomized to catheter ablation versus medical therapy while waiting. And the primary endpoint was composite of all-cause mortality, worsening heart failure, and transplantation or implantation of LVAD. And the surprise, much improvement and much higher, much less incidence of the primary outcome in the patients subjected to ablation. And the study was stopped early for efficacy. These are the Kaplan-Meier curves proving much improvement in this case. The limitations in this Castle HTX trial, not Castle AF, it is a single center study. It was terminated early, so maybe if it was prolonged, maybe the results will differ. The open label design might have influenced treatment decisions, and some patients crossed over from between the two groups. However, it has an impact on clinical practice because these patients with end-stage heart failure eligible for heart transplantation were not before tested, and this also takes us again that patients with very reduced ejection fraction, some of them may benefit from RF ablation. Mr. Chairman, my conclusion, heart failure and atrial fibrillation share common risk factors. Both have a negative impact on morbidity and mortality. In heart failure patients, rhythm control of AF has been shown to be superior to rate control with regard to hard endpoints like mortality, morbidity, worsening of heart failure. For AF rhythm control, catheter ablation has been proven to be superior to medication. And in some heart failure patients, AF ablation should be regarded as one of the primary therapeutic options and is a potential pillar of treatment if well directed. Finally, not all patients with atrial fibrillation and heart failure should be referred.
Preoperative atrial fibrillation. My agenda includes a definition, incidence, impact of perioperative atrial fibrillation, pathophysiology, prediction and prevention, and management strategies. Perioperative atrial fibrillation describes the onset of the arrhythmia during an ongoing intervention. Post-operative atrial fibrillation, defined as new onset atrial fibrillation in the immediate post-operative period, with peak incidence between the second and the fourth day and resolving within 4 to 6 weeks. Perioperative atrial fibrillation thought to be transient, occur in about 20 to 50% of patients after cardiac surgery, 25 to 40% after CABG, 30 to 40% valve patient, 10 to 30% after non-cardiothoracic surgery, and 5 to 10% after vascular or large colorectal surgery. Many episodes of post-operative atrial fibrillation are self-terminating and some are asymptomatic, but post-operative atrial fibrillation has been associated with 4 to 5-fold risk for recurrent atrial fibrillation in the next 5 years. Also, perioperative atrial fibrillation carry more risk for early stroke and early mortality when compared with non-operative atrial fibrillation. Also carry more risk for long-term stroke and long-term mortality when also compared with non-operative atrial fibrillation. New onset post-perioperative atrial fibrillation associated with increased risk of stroke and mortality, both in the short and the long term. With a subgroup analysis, patients with a cardiac surgery, patients in a patient undergoing non-cardiac surgery carry a higher risk than patients with a non-cardiac surgery. And it is reflected on the guidelines recommendation, as we will see in the next slides. Perioperative AF also associated with hemodynamic instability, prolonged hospital stay, more infections, more renal complications, more bleeding, increased in hospital death, and greater health care costs. As regards the pathophysiology, a perioperative AF often require trigger and vulnerable atrial substrate, but the definite mechanisms remain elusive. The summary of the risk factors for atrial fibrillation in general, which is a coronary artery disease, vascular disease, acute illness, physical inactivity, lipid profile, alcohol consumption, smoking, obesity, obstructive sleep apnea, COPD, inflammatory disease, chronic kidney disease, prediabetes, hypertension, valve disease, heart failure. But in perioperative atrial fibrillation, the risk factors may be the same: hypertension, ischemia, valvular disease, heart failure, obesity, obstructive sleep apnea, and atrial fibrillation, male sex, history of AF, previous AF. But also there is specific triggers here in the form of increased in adrenergic drive and change in the vagal tone, local and systemic inflammation from cardiac procedures, hypoxia, anemia, vasopressor, and hypoglycemia and electrolyte imbalance. Prediction for perioperative atrial fibrillation not included in the previous scores, Euroscore, which predict mortality, renal failure, permanent stroke, prolonged ventilation, infection, length of stay, and reoperation, but no atrial fibrillation. Recently, there is no current standard model to predict the risk factors, but from the previously mentioned risk factors, help speculate patients' risk of perioperative atrial fibrillation and stroke. Multiple strategies to reduce the incidence of perioperative atrial fibrillation with pre-treatment or acute drug treatment have been described, but there is a lack of evidence from the large randomized controlled trial. But amiodarone is the most frequently used drug for prevention of perioperative atrial fibrillation. This algorithm for prevention for all patients on beta blocker should continue beta blocker. And patients with hypomagnesemia may be IV magnesium may be considered. Digoxin, catheter or surgical ablation not recommended. For patients with intermediate to high risk, the IV amiodarone should be considered. Diltiazem for patients with preserved left ventricular ejection fraction, if not taking a beta blocker, should be considered. In patient for oesophageectomy, IV amiodarone may be considered. For high-risk patients, left atrial appendage excision may be described at time of surgery for patients with AF or who are not candidate for anticoagulation. The trial about colchicine for the prevention of perioperative atrial fibrillation, which underwent on patients with a non-cardiac major thoracic surgery, excluding lung transplantation, under general anesthesia, which enrolled more than 3,000 patients. The study was randomized, international, multi-center, double-blind, but the result wasn't significant as regard clinically significant perioperative atrial fibrillation, myocardial injury in non-cardiac surgery, composite all-cause mortality, myocardial function, and hospital length stay. About prevention of thromboembolic events in patients with perioperative atrial fibrillation, as a non-perioperative atrial fibrillation, uses of oral anticoagulation lower risk of thromboembolic events. But here we have a trial on the patients post-CABG. When compared the patients who received oral anticoagulation with the patients who didn't receive oral anticoagulation, there was no significant difference as regard myocardial infarction, ischemic stroke, or embolization, but there was more bleeding in the orally anticoagulated group. This result wasn't a difference when the patients subclassified according to the CHA2DS2-VASc into above 5 and below 5. So the management strategy stated that for all patients, minimize inotropic agents, optimize fluid status, correct electrolyte or other metabolic imbalance, and further specific management should be designed according to the patient profile. As regard hemodynamic stability, if the patient is stable or not, duration of new onset perioperative atrial fibrillation, to decide for a cardioversion, pharmaceutical or electrical, and for rate control or anticoagulation. The ESC recommendation for management of perioperative atrial fibrillation stated that amiodarone or beta blocker is recommended for prevention of postoperative atrial fibrillation after cardiac surgery. Beta blocker, especially in patient who was on beta blocker. As regard long-term anticoagulation should be considered for a postoperative atrial fibrillation after non-cardiac surgery. And the long-term oral anticoagulation therapy may be considered for patient postoperative AF after cardiac surgery. Beta blocker shouldn't be used routinely. As I said before, beta blocker should be continued when the patient is on beta blocker. And this is the diagram about management of postoperative atrial fibrillation. Preoperatively, patient should be assessed for and optimize hemodynamics, correct electrolyte, identify patient at increased risk for postoperative atrial fibrillation, and management according to the hemodynamic. As regard the rhythm or rate control will be decided according to the patient profile. Thank you.
Dr. had a question, Professor Samir.
Patient got atrial fibrillation after cesarean section. When to start anticoagulants after 24 hours or 48 hours?
The onset of starting anticoagulation after operation should be discussed with the surgeon, and the balance about the risk of bleeding, the risk of embolization should be respected. Patient with atrial fibrillation who have a high risk for stroke, patient multiple risk factors, patient with valvular heart disease, patient with prosthetic valve, the risk of thrombosis is very high. But if there is a low risk for stroke or embolization with a high risk of bleeding, complicated surgery, there was a bleeder in the operation, so the issue when to start should be discussed with the surgeon.
And in that regards, would you use low dose or high dose NOACs?
Low dose or high dose NOACs?
Are there data, or would you have anything to suggest?
Low dose or high dose according to the bleeding risk. I think elderly, renal impaired patient with major surgery, I think those patients is subject to low dose with a lower therapeutic target.
I think there is some study that speaks that low dose is effective, especially in reverse spire. In American College
15.
Cardiology 12 to 18, it showed that 10 milligram equal to 15 to 20 in prevention of stroke with low risk. And I again also in DVT and pulmonary embolism recommended the 10 milligram for prevention, which has very low bleeding risk.
As an alternative, you could consider early cardioversion.
Early cardioversion.
Early detect, early cardioversion the patient. This way you eliminate in this high-risk patient.
Yes, if
Even
recent, yes,
even
if
even
recent.
if the patient hemodynamic stable with the mild symptoms,
Yeah, just to eliminate the need of anticoagulation for a while.
If recent, they are sure, but if no history to know when it happened, I'm afraid to cardivert.
usually patient assess the preoperative, but as my professor said, if the patient, we don't know the onset of the arrhythmia. This is a dilemma. At this time, you prefer to cardiovert.
If the patient had already atrial fibrillation, of course you have to manage the patient as a patient with atrial fibrillation that
Chronic.
undergo
Yes.
Resistant.
surgical intervention. If the atrial fibrillation occurs just after the intervention, when he is in the intensive care unit,
Recent.
then you can consider early atrial fibrillation. Maybe you can use also antiarrhythmic drugs to prevent recurrences. But this is an empiric way. I don't know if there are studies demonstrating that this effect, probably not. But it's an empiric way to
Try
manage
Anna.
patients that develop atrial fibrillation just after cardiac surgery.
The-
Avoid use of anticoagulation, at least in the risky phase.
The situation is rare, but occur. We facing a patient pre-operative fitness for the operation, and we suddenly discover the patient atrial fibrillated without symptoms, with unknown onset. Here, even the patient had multiple risk factors, hypertensive, diabetic, but he will underwent operation. What about anticoagulation? Start the postpone operation if elective. Don't start anticoagulation and do surgery.
I would start and I would stop according to the recommendation for the surgery. I could replace as soon as possible according, as you said, the opinion of the surgeon should be discussed. I perfectly agree with you.
Thank you.
If no more question, any more question? So we'll close the session. Thank you, Professor Said.